Thank you, Lloyd, and your team from the Africa Health Network to give me some time on sex hormones and in chronic kidney disease, but I've just put it as sex hormones and the kidney. In the next 30 minutes or so, I'll discuss a little bit about sexual function in chronic kidney disease, the role of sex hormones in disease progression other than chronic kidney disease, a little emphasis on cardiovascular disease, then sex hormones and how it impacts progression of chronic kidney disease. Now, the clinical implications of this sexual dimorphism in chronic kidney disease, therapeutic implications, do we even consider treating some of this dysfunction? And a last couple of slides is that we always think of human beings as man and woman. We forget that we are actually beyond this binary, and a lot of things actually make us a human, a woman or a man, and conclude in the end. Now, sexual dysfunction in chronic kidney disease is underreported and also under-recognized. There is significant functional impairment and which actually impacts the quality of life in this unfortunate patients. A lot of physiological and pathological changes occur in chronic kidney disease, and they may have a major impact on sexual function in chronic kidney disease patients. Most important changes are the hormonal changes, which I will be talking. There are other issues like the comorbidities that are there in our patients, like diabetes, hypertension, advancing age, the medications these patients take also contribute this problem of sexual dysfunction in chronic kidney disease. A few words about dysfunction in men. The commonest important factor underlying sexual dysfunction in men are the hormonal disturbances. And one of the commonest physical manifestation of this is erectile dysfunction in men with CKD. Most of these disturbances are actually also associated with the comorbidities that they have, like diabetes and hypertension, and also some of the medications that they take, like antihypertensives, antidepressants, ranitidine, etc., all impact erectile function in men. And also because of their chronic kidney disease, men have a very low self-esteem. They have a poor body image because of their fistula and other issues. And almost 30 to 40% of men with chronic kidney disease have depression. All these factors together, complex interplay, lead to the sexual disturbances in men. The hormonal differences that we see is that the pulsatile nature of LH secretion is actually maintained in men, but the pulses are diminished. Please note this is a little different in women compared to men in CKD. In men and women, the baseline luteinizing hormone levels are high. That is because of the negative feedback hormone, that is testosterone, is very low in men. Because the primary problem in men is hypogonadism, secondary to the testicular function. That's a major important thing. Even though hypothalamic derangements are there, where the pulsatile LHRH release is reduced, and even if you use goitropin releasing hormone infusion, still LH release is low in men. So there are both hypothalamic pituitary abnormalities in men, but the major problem with men is the low testosterone levels. And that has been shown in 40 to 60% of men in hemodialysis. It actually worsens as the GFR drops. Men on HD have very low testosterone levels. The testicular size is smaller, and testicular biopsies have shown fibrotic changes. And the release of testosterone to beta HCG is also reduced. So hypogonadism plays a major role in the hormonal differences in men. And like in women, because of reduced clearance and other problems, prolactin levels are high, which leads to a reduced libido, reduced muscle mass, and men with CKD, as you know, develop gynecomastia and infertility because of all this hormonal differences is very common. And the next problem, the clinical manifestation of this hormonal dysfunction and various other factors is erectile dysfunction. Again, the incidence increases as the GFR drops, and almost 80% of patients in dialysis have some form of erectile dysfunction. Unfortunately, we never discuss this with our patients. And not only the hormonal factors which make a difference, but then there are other factors like impaired blood flow, the atherosclerosis of the penile vessels, and the endothelial dysfunction secondary to chronic kidney disease also adds to this problem of erectile dysfunction. But the most common important factor underlying erectile dysfunction is the low testosterone levels. And low testosterone actually lead to a reduced smooth muscle cell structure, function, innervation, and maintenance of the fibroelasticity of not corpus callosum, but corpus cavernosum, I'm sorry. And centrally, the low testosterone levels actually reduce their libido and sexual desire, leading to a very high incidence of erectile dysfunction. The mechanisms of erectile dysfunction in chronic kidney disease are multiple. As we said, low blood flow because of atherosclerosis, endocrine because of low testosterone levels and high prolactin, neurological, uremic, and diabetic autonomic neuropathy leads to problems with erection. Then the drugs that we have for these patients, mainly antihypertensives, and two other major complications of chronic kidney disease like anemia, which leads to reduced blood flow to corpora cavernosa, and hyperparathyroidism. Because hyperparathyroidism has a very intricate link with testosterone levels, and it has been shown that if you do a parathyroidectomy, actually the testosterone levels increase in men with chronic kidney disease. Besides the hormonal and clinical obvious factors, and the various other factors like depression, neurogenic factors also cause problems. Low erythropoietin, which affects sexual function, vitamin D, reduced minerals, all add to erectile dysfunction. The importance of hyperparathyroidism and penile vascular calcification is noted in this case. A case we had a similar one because of such low blood flow. This patient came to our emergency with penile gangrene and leading to requiring amputation. Hypogonadism not only impacts erectile dysfunction but also is responsible for the fertility issues in men. Fertility in males is suboptimal in CKD patient, and almost in dialysis patients, 40% of them show oligospermia and azoospermia. They also have abnormal quality of the sperm, motility, morphology, and density. Besides hormones, various other factors like uremia, oxidative stress, and chronic inflammation characterized in chronic kidney disease is responsible for this subfertile males in chronic kidney disease. Even sometimes patients with ADPKD have seminal vesicular cysts, which also impair male fertility. And drugs, most of our patients, when they have for their treatment of various diseases like lupus and all, cyclophosphamide, etc., also reduce the fertility in male with chronic kidney disease. Now, briefly, a little bit about sex hormone abnormalities in women. I'll go through the clinical issues. The manifestations are much more prominent in women and much more important because these are women who will sometime or the other come and discuss about reproduction. I'm not discussing that because of want of time, but it's important to understand, and most of us actually address these hormonal abnormalities in women more frequently than we do with men. Now, 85% of women with CKD report some form of menstrual disorder. 39% had premature menopause, and almost in women with less than 40 years of age with any form of chronic kidney disease, 20% had some form of menopause. Please understand this menopause can be reversible, which is an important phenomenon because when you start dialysis and if the uremia is reversed, chances of getting pregnant is higher, and sometimes pregnancy is missed in women with on dialysis. 58% the commonest menstrual symptom is amenorrhea in dialysis, and 65% of patients, as we said, almost have never have menstrual cycles when they have been initiated on dialysis. And it is directly proportional to the stage of chronic kidney disease. Sometimes the underlying cause of chronic kidney disease like type 2 diabetes or SLE also contribute to the endocrine dysfunction in women with CKD. Conventional hemodialysis does not correct the hypothalamic dysfunction. So if you really want a woman who aspires to become a mother, you should be offering them high intensity dialysis early on. Also, absence of menstrual cycle does not imply that there is a permanent ovarian failure. Ovulation and pregnancy is still possible if the uremic factors are corrected. Because of this problem of irregular periods, pregnancy in hemodialysis patients are often diagnosed very late, and delay in the diagnosis, because when you diagnose a woman with pregnancy, you need to intensify dialysis. This delay in diagnosis actually delays intensification of dialysis and also delays withdrawal of some of the drugs which these ladies are on, and impacts the fetal outcome. So in your clinical practice, always have this conversation with women on dialysis, discuss contraception, find out what are their desires of becoming a mother, and accordingly counsel them. Transplantation often restores not just fertility in women, but also in men. The hormonal dysfunction in women are a little more complex. Here, hypogonadism is not the primary problem. It is the disruption of the hypothalamic pituitary gonadal axis in women. And here, what happens is the estradiol-mediated pulsatile secretion of GnRH is lost. The GnRH pulses comes down. The release of LS and FSH pulses also come down, even though the levels of LS, luteinizing hormone, and follicle stimulation hormones are high. But the pulsatile nature, which characterize the endocrine function, reproductive function of women, is completely abrogated. Here also prolactin plays a major role in the dysfunction in the hypothalamic pituitary axis. So women with CKD have high prolactin, high LH, and high GnRH levels because of reduced clearance. And there is also a loss of cyclic pulsatile gonadotropin release. The loss of pulsatile LH and FS release actually eventually leads to the loss of estradiol and progesterone effect on the endometrium, leading to infertility. So the defect in hypothalamus in pituitary leads to an increased levels of these hormones, but there is no surge, the mid-cycle surge in this hormone. And because of these issues, women often have anovulatory cycles. They have lack of cyclicity, and because of the lack of finally reduction of estrogen and progesterone, because of high prolactin, they develop premature ovarian failure, and the uterine endometrium is not maintained because of loss of these two hormones, leading to final uterine atrophy and making pregnancy altogether impossible in this woman. Even in women, various other factors, polypharmacy, hypertension, this uremic changes, even malnutrition, which is more common in women, inflammation, etc., adds to the gonadal dysfunction in CKD. To summarize, the fertility, subfertility in women is mostly predominantly because of abnormal hormone levels, much higher LH and FSH. In men, it is LH-PRL. The primary hormones, estrogen and testosterone, are reduced in women and men. Most important function is the loss of cyclicity of sex hormones in women. In men, the hypogonadism because of low testosterone, leading to sperm quality and quantity issues, and of course, central reduction in sexual function. Women, because of this abnormal cyclicity and abnormal ovulation, they have menstrual disorders like functional menopause, endometrial abnormality, and reduced ovarian desire. Now, how does sex hormone impact disease progression in chronic kidney disease? I'll spend a few minutes with cardiovascular disease progression and briefly discuss the role of hyperprolactinemia and testosterone in cardiovascular mortality. And of course, hypoestrogenism or low estrogen in chronic kidney disease has its various other problems of various diseases. A wonderful study, or a very important study in JASN published, actually showed that there is a very strong link with low testosterone levels and mortality in male dialysis patients. Male dialysis patients who have a low testosterone level have a significantly higher mortality. And not only overall mortality, but the cardiovascular mortality in men with lower testosterone levels actually is responsible for higher cardiovascular mortality. This testosterone deficiency in men is actually associated with traditional cardiovascular risk factors like dyslipidemia, obesity, metabolic syndrome, insulin resistant, and diabetes mellitus. And also there are direct pathogenic effects of testosterone in these men. The atheroprotective effect is lost, There is vasodilation is reduced in coronary and central arteries, mostly maintained by nitrous oxide. There are endothelial dysfunction, reduced nitric oxide, and there is a reduced perfusion in myocardium secondary to exercise or any other stress. So testosterone has its impact on traditional cardiovascular risk factors and a direct effect on cardiovascular. Testosterone and erectile dysfunction are completely linked in a very complex manner with cardiovascular risk. Chronic kidney disease, hypogonadism, and ED are all linked with endothelial dysfunction, inflammation, and traditional CV factors, which lead to increased cardiovascular disease. A low estrogen level in women also is responsible for various risk factors of disease. It's very important to know that women with advanced stage of chronic kidney disease actually have a higher risk of death with cancers and also with cardiovascular death. Women on dialysis have a very high prothrombotic state and their fistulas fail much faster than that of men. The immunomodulatory effects of estrogen is responsible, and talk a little bit about an increased incidence of lupus nephritis, and even a low hypoestrogen levels are important for cardiovascular risk. And this is the commonest cause of death in women in CKD. The protective effect of estrogen is there in women as long as they are menstruating. The moment they attain menopause, the risk of heart disease is the same as that of men. Women on CKD actually have a functional menopause, and hence women on dialysis, whatever their age, a 35-year-old woman on dialysis has the same risk of cardiovascular death as a 35-year-old man. So women on dialysis have a similar cardiovascular risk. And this is being told to be because of an increased prolactin levels, which actually leads to an increased cardiovascular risk. Besides the cardiovascular problems, a low estradiol leads to reduced bone mineral density, progression of kidney function, dyslipidemia, infertility, menstrual disorders, and of course, reduced libido. A high prolactin level is a common feature in chronic kidney disease because of reduced clearance. And because of that, there are a lot of increased levels of prolactin fragments which are cleaved by bone morphogenic protein 1 and cathepsin D. And these fragments are called vasoinhibins. These vasoinhibins are responsible for migration of endothelium, reduced vasodilation of endothelial cells, and increased apoptosis, leading to an increased cardiovascular risk. So prolactin not only affects sexual function and hypogonadism in males and females with CKD, but also on cardiovascular disease. Now, how does sex hormones impact progression of chronic kidney disease? This is a binary which we all know. Women have a higher incidence of early chronic kidney disease, but as we reach CKD stage 5, the numbers come down and men make a majority of it. Some people say this may be because of even socio-cultural factors by lack of access to care in CKD stage 5 for women, but there is physiological reasons for that. And one of the reasons is the kidneys in men and women are different. Men have a larger size kidney. The renal hemodynamics is much more vasoconstricting in nature in men. There are various transporters in the kidney which are influenced by estrogen. I'll be talking about it in the end and in next few slides, which impact the overall tubular function and salt sensitivity in women. Glucose transport, the SGLT2 protein expression and transporters are modulated by estrogen and higher in female. Water absorption, aquaporin is more in males, and organic transporters are actually much more expressed in male. This is very important because it's been shown that OA2-1 is maybe in 1, whereas OA2-3 is actually in less and in males. It is important because the organic anion transporter 3 is one of the major transporters which actually transpose drugs in the proximal tubule. And this is one of the reasons we believe is that women have a higher drug toxicity than compared to men. Now, we all know that majority of the studies have shown that the women have a higher incidence of women in early CKD. This is a study published in European Medical Journal from Norway. So most of the studies, except the other ones, have shown that women have a higher incidence of early CKD. But when it comes to the development of end-stage kidney disease, majority of studies have shown that men outnumber women in stage 5 chronic kidney disease. There is a differential progression of chronic kidney disease. There is a more rapid decline of GFR in men. Certain diseases like IgA nephropathy, membranous, ADPKD, chronic kidney disease of unknown origin progress faster in men. Estrogen is implicated in higher prevalence of lupus nephritis, but again, progression is faster in men. Diabetic women actually have a higher, faster decline of GFR, and also a mortality is actually higher in men. And finally, the association between progression with GFR and proteinuria is actually more robust in women. At a given level of GFR and proteinuria, the association of cardiovascular disease is much more robust in women than in men. This is the study from Jason, which all showed that in the CKD cohort, women had a lower risk of progression. Another study which very clearly shows that when the woman is a younger age and actually has some amount of menstrual function, the progression is a little slower. Men have a faster progression, but the slope again increases as women become menopausal. So the benefit of hormones are lost as far as progression to ESKD is. So why is it so? Because there has been studies which have shown that estrogen receptors are present in the kidney, and estrogens affect negatively with the levels of RAS blockade, reactive oxygen species, nitric oxide, and various growth factors where testosterone positively impacts them. Sex hormones, especially estrogen, has beneficial effects on the RAS system, kidney energy metabolism, reduces fibrosis, actually reduces endothelial dysfunction, oxidative stress, and inflammation. These studies have shown that estrogen is protective for kidney function. As far as renin-angiotensin system is considered, estrogen negatively affects RAS, whereas androgens are positive. The negative effect on RAS actually leads to the reduction of aldosterone, reduces pressure, blood pressure, increases natriuresis, and reduces reactive oxygen species in women. So finally, there is reduced sodium absorption, there is reduced oxidative stress, and there is a reduced vasoconstriction in women because of its effect through estrogen. Estrogen works through mesangial cells, podocytes, and glomerulus through its receptors, estrogen receptor 1 alpha and estrogen receptor beta in the kidney. And because of its beneficial function with TGF-beta, renin-angiotensin system 2, it reduces glomerulosclerosis and podocyte apoptosis. So estrogen is actually protective for chronic kidney disease progression. As we discussed earlier, it's lost in menopausal women, and in menopausal, they are back to a higher salt sensitivity, higher incidence of hypertension, CVD, and progression of CKD. This is a clinical implication. Postmenopausal women in chronic kidney disease, because their salt and water absorption is similar to men, we can use diuretics as antihypertensives in these women. And it's also been shown that there are various other abnormalities in the tubular transports in nephron. To just give a basic idea, estrogen works through various transporters and leads to reduced aquaporin expression, reduced sodium phosphate co-transporter expression, but increases the sodium hydrogen expression and in male via testosterone, the URAT1 receptor expression is high. In the distal tubule, the sodium chloride channels are expressed more by ladies. And this has its implication that women actually have less salt sensitivity, but higher incidence of hypokalemia because of this differential expression of various transporters secondary to estrogen. SGLT2 expression in estrogen is much, much higher in women. So the implications of the sexual dimorphism in chronic kidney disease is there is a differential risk factors of cardiovascular disease, chronic kidney disease. There is also an implication that biomarker estimation in women are different. Estrogen modifies biomarkers excretion in the urine. And not only estrogens, but biomarker excretions are different at different phases of menstrual cycle. And that is why when we know women and men respond differently in various stages of chronic kidney disease, we need to have the equal representation of both genders in chronic kidney disease trials so as to have proper observations and conclusions with this. And then there is, of course, a gender difference in drug handling. As we discussed, the pressure, increased pressure natriuresis, reduced salt sensitivity is more common in women. They have lower potassium, they have lower serum uric acid. They, because of the sodium hydrogen exchanger expression, the urine is often alkaline, and this leads to lower stone disease in women. Women also have lesser incidence of hypertension and hypertensive associated acute kidney injury, and they have a higher autoimmunity. This is because of the hormones expression in women. They often have a Th2 expression leading to the estrogen receptor alpha, estrogen receptor beta expression, causing T cell proliferation and leading to a production of more of an antibodies. And so women have a higher incidence of autoimmunity, and whereas men have a higher incidence of cancers. The difference in biomarkers are very important and plays an important role because of an hormonal differences. Troponins are actually lower in women. So we often, because the levels don't rise, we often underdiagnose acute coronary syndrome in women with CKD. CRP on the other hand is higher in women. And this is modified by menstrual cycle and use of oral contraceptives. It's important to know this. A higher CRP does not always mean higher inflammation in women with CKD. Various other biomarkers are excreted differently, like cystatin C, fatty acid binding protein, alkaline phosphatase, gamma GTP, beta-2, microglobulin, etc. So we need to develop databases which actually looks into the sex differences in biomarkers, and then we decide which levels are appropriate for diagnostic and prognostic path. Because of this difference of hormonal differences, women need to be represented equally, and this is very important in some studies. One study I'll take is DAPA-CKD. If you look at DAPA-CKD, there were only, if you look into the male and female representation, 1/3 of the patients in the treatment group were only women. In the placebo group, similarly, only 1/3 of women were represented. But if you analyze the supplementary data and look into the side effects, the overall AKI, 88% of AKIs were in females. So, and this could be related to the difference of hormonally mediated SGLT2 expression in women. Also, drug handling. We almost always write drugs of a fixed dose with men and women. We forget that there is a difference in BMI and surface area of drugs. There's a whole lot of interaction between estrogens and ACE inhibitors and ARBs. There is a higher risk of acute coronary syndrome and women and myocardial infarction in women who are on ACE inhibitors than ARBs. Similarly, heart failure is more common in elderly women who are on ACE inhibitors than compared to ARBs. So maybe in our clinical practice, if we want to RAS block it, we should prefer ARBs in women. There is also the clearance of CNIs and mTORs are higher in women. Important to note this, we may have to measure levels more, whereas the clearances of MMF and glucocorticoids are much, much lesser in women. In men, women usually have a slower gastric emptying time and reduced acid secretion. So drug absorption, especially in chronic kidney disease, where we are using PPIs very commonly, may be very different in women with chronic kidney disease. And as mentioned, the differential expression of tubular transporters, which are hormonally mediated, actually also leads to differential renal handling of drugs. The OAT3 overexpression in women actually leads to much more higher risk of drug toxicity in women. Now, therapeutic implications, we can discuss with our men patients and consider erectile dysfunction. We should, if they report higher incidence of ED, we should look into the antihypertensives, beta blockers, calcium channel blockers, clonidine, all interact or impact ED. We may need to modify the drugs if required. Zinc supplementation have shown to improve ED. Can try that. Some people have used bromocriptine to reduce prolactin level, but that is not important. But we should also, like other patients, offer them phosphodiesterase 5 inhibitors. And there are some trials with the use of sildenafil and tadalafil in patients, in women, in men with CKD and erectile dysfunction. There are small reports of using surgical intervention like vacuumtumescence and penile prosthesis in men with erectile dysfunction. Hormonal therapy in women have been used in CKD patients. Estrogen supplementation has been used in some postmenopausal women, and mentioned a study which has shown actually that estrogen has been renoprotective and reduced deterioration of renal function. Oral estrogens have a higher side effects. Non-oral preparation like patches or dermal preparations are beneficial. In young hemodialysis patients actually who are going to be on dialysis for a longer time, estrogen can be slowly used to regularize their menstrual cycles, improve their libido, and also improve their osteoporosis, and finally offer them a better quality of life. Naloxone is a selective estrogen receptor modulator which has been used for bone osteoporosis in women. This study in Kidney International, which after a post-hoc analysis actually showed that women who were on naloxone actually had a slower decline of renal function. So this is a tantalizing prospect of using a drug for a different indication and have another benefit of reducing decline. Testosterone has been also used in smaller studies in sexual dysfunction in men. Usually, again here, oral preparations are not preferred. Intramuscular injection or transdermal preparations are beneficial. They improve libido, but the improvement of the central desire is much more than the peripheral action. It does not improve erectile dysfunction that much, improves the mood, and generally reduces depression. Is also used for treatment of bone disease and anemia. When we were student, test androgens were used for treatment of anemia, but his use has come down because of his hepatotoxicity, benign prostatic hyperplasia, exacerbation of OSA, and polycythemia. Clomiphene citrate has been used in some studies to improve testosterone levels in men. Now, what is the clinical implications in our practice after we have gone through this? This is a very important study from Canada, which had shown that they have talked to 171 nephrologists and 121 allied health personnel, which have shown that 95% knew that kidney function affected sex hormone status in men and women, but only 1/3 of them discussed fertility with patients. Leave alone fertility, I don't think any one of us ever discussed erectile dysfunction with our young male patients. And they believe that patients actually wish to discuss fertilities, especially the younger ones, but we don't give that much of importance to them. Transplant nephrologists discuss fertility more, which is true. We are more aggressive about pregnancies in kidney transplant recipients, but we don't put our energy on hemodialysis patients. So nephrologists are actually aware of the impact of gender differences, but rarely discuss these issues with men and women. And I have not seen any engagement on erectile dysfunction. Minimal discussion, and of course, we make very little effort to minimize this major cause of distress in our patients. A few words about gender beyond the binary. Now that we have understood that all human beings cannot be typed as men and women and have the same kind of treatment offered to everybody. What I offer to a 35-year-old man with chronic kidney disease may not be the same for a 35-year-old woman. But then we have to understand gender is much, much more a fluid concept. Gender is the identity, a social cultural roles, which our society gives us because of our behavior. But sex is actually our physiological attributes, which is characterized by the hormones that are present in our body. So sex and gender are actually not interchangeable. Women, men are not synonymous or interchangeable to male and female. A woman is not a female and man is not a male always. There are differences in gender-related difference in access to care because of social cultural. The woman in me actually sees that I am more adherent in medicines, whereas men don't do because of a social cultural milieu. And these sex-related differences also lead to response to therapy. This is a wonderful article. This has come out in CJASL last year from Sophia and Ahmed from University of Alberta. So when you discuss clinical trials. First question you ask to discuss what is the sex and the gender of the patient. Sex can be a man. The men with his XY genes having a same level of testosterone can still have a lot of feminine qualities. So it may be, he may be a man, but he may not be that masculine. And is there any other factors, the gender factors or genetic, sociocultural factors will modify the results? As we discussed, medicine adherence in a woman is better. It's also better in a man who has a more amount of feminine qualities of caution, qualities of discipline, etc. Then we have to realize what was the sex assigned at birth and what is the current gender identity. These things are becoming very common in our part of the world also. And we then have to look at the femininity and masculinity, and then we look the hormonal status as the woman. In India, there are many of women who have undergone ovariectomies immediately after completing their family. Is their reaction to drugs similar to that a woman who has her ovaries or has a similar hormone levels? Similarly, is there any other things? Are they on medicines? Like elderly men are on androgens or estrogens for their treatment of prostatic cancer. Will that modify their response in chronic kidney disease? Will these drugs in a man who has drugs which reduce their testosterone levels increase their cardiovascular mortality, or will it be renoprotect? So these are things which we need to understand when we discuss. We need to go beyond. We are still at a level when we take all patients as gender neutral. I write the same dose of cevalomar carbonate to a 40 kg woman compared to an 80 kg man. We do the same thing. We don't think of all this. But I think we need to go beyond that. Even if a woman is sitting in front of me, I need to understand her gender may be, her sex may be a woman, but is there any sociocultural attributes which makes her much more prominent or towards a man? Similarly, with a men with all the same levels of testosterone and all the male hormones being normal and same, does he have other qualities which makes him a little more feminine compared to what his gender says, what his sex says? So these are things which we need to think when we prescribe our medicines to this group of patients whose physiology is anyway altered by uremia. So ladies and gentlemen, there are important differences in sex hormone related to kidney anatomy and physiology. Hormonal differences are responsible for differential progression of various diseases, and sex hormone diformism plays an important role in development of hypertension and renal stone disease in our patients. Altered sex hormones in CKD impact progression of CKD, libido, erectile dysfunction, menstrual disturbances, fertility issues should be part of discussion of all our chronic kidney disease patients. Thank you very much for your kind attention.
Thank you so much, Dr. Urmila, for the nice presentation in extensive topic of hormones in CKD, sexual hormones. So now I'll just like to start with the questions from questions and answers. And if everyone has either want to comment or talk, they could raise a hand. Otherwise, they can write their questions on the chat box or in the question and answer box below your Zoom webinar. So we have one question from Dr. Mazhar Amilari. He's saying, thank you, Dr. Anandh, for this comprehensive talk. It has improved my knowledge on this topic exceptionally. I would like to ask regarding hormone replacement therapy in female. Will prescribing hormone replacement therapy not increase the risk of cancer and risk of thromboembolic event in these women?
Thank you, doctor. Thank you very much for this question. I think because of lack of time, I did not discuss this. Hormone replacement therapy is actually not indicated in women with chronic kidney disease. And in fact, it is not indicated in women with who don't even have chronic kidney disease. The replacement of estrogen is considered in patients who have osteoporosis, who have bone issues. In them, it is not even the traditional hormone replacement therapy. We don't use estrogen, progesterone, oral pills. What we use is the drug that we have, the Kidney International study, which some of our orthopedic surgeons also use, are the selective estrogen receptor modulator, raloxifene. That has been used in women for their osteoporosis and bone disease. And serendipitously, it has been shown to improve renal function, and it has arrested the decline of GFR in this patient. So it is not the traditional HRT that we use. What we use is SERM, the selective estrogen receptor, in a small group of patients where bone disease makes an important decision. And then there are smaller studies where very small studies, where young women who want to regularize their menstrual cycles, who want to have a pregnancy. There are studies from Georgina Piccoli's group where they have tried to do this for women to get their libido back, have some sexual activity and get pregnant. That has been done, but the flip side of it is very high rates of fistula thrombosis. These are young women. They don't have stroke risk or cardiovascular risk that high, but they clot their fistulas very high when they have been given transdermal or like the methoxyprogesterone patches to improve their sexual function to help them get pregnant. Not been very successful. Similar hormonal replacement therapy has been done in men to achieve men testosterone levels are subnormal. It is just been given in a fashion titrating the drugs to get into a normal testosterone levels. So, and that is very difficult. You don't know what dose will maintain what testosterone level. There have been small studies which have been done to bring normalized serum testosterone levels in men. And that has shown a beneficial impact in their cardiovascular mortality. And these have been studies done in younger people who are going to be on dialysis for a longer period if they don't have any transplant prospects, and whose complications, the non-chronic kidney disease complications, will be increased. That's all.
Thank you, Doctor. So in the same line, Dr. Faustin Magomola is also asking, HRT is protective. Is it possible to be used for the patient already have CKD?
Not the normal oral HRT. If you can discuss with your endocrinologist or gynecologist, there are newer drugs which they use for improving some of the clomiphene citrate is being used for fertility studies. We have used in our hemodialysis patients all these drugs for improving fertility and increasing ovulation. Please understand, all these young women may be having no menstrual cycle, but they still have some amount of ovarian reserve. Some amount of ovulation simulation drugs can improve and can lead to ovulation. In our country, some women have actually taken the advice of fertility experts and have actually tried to conceive. But then again, there are complications. One of the major complications of this is the hyperstimulation syndrome. I have seen some of my patients have come back with cross ascites. A couple of patients I remember who were on clomiphene citrate to improve ovulation and their fertility. So it's a very tightrope that you walk. We don't use it, but then we don't discuss this with our patients also. We don't know what they want, what is their aspirations. They have such poor, low self-esteem, and they're so worried about their quality of life. For them, it is like coming to dialysis one day and going back home the next day. Many of us have never asked, would you want to be a mother? And then you can always find out the less toxic medications, not the straightforward oral contraceptive pills or estrogen supplementation. There are newer drugs, newer methodology to help them improve fertility. As far as osteoporosis and cardiovascular risk profile are concerned, the basic metabolic aspirin, clopidogrel, and of course, using various other, it's a different talk altogether, using PTH, denosumab, and all those things.
Thank you, Doctor. We have another question from Dr. Witness Lubomba. She's saying, I have a patient on hemodialysis for 5 months. He was also diagnosed to have BPH, and he was started on finasteride and tamsulosin. He claims 2 months after starting the drugs, he started experiencing erectile dysfunction. What is the next step? I'm in the setting where hormonal assay is not done.
No, I think you're right, ma'am. Some of these drugs do cause erectile dysfunction. So it has to be, how old, what is his BPH? Is it only medically amenable or it can be taken care of by surgery, ma'am? The surgeons don't want to operate on him.
Dr. Witness, if you can write or you can raise your hand and
It
talk.
doesn't matter. Our solution will be, if his erectile dysfunction is distressing him, it is better to withdraw the drugs, get the BPH sorted out surgically, and then not use finasteride, dutasteride and all. These drugs have their indirect effects and they interact with many other of the antihypertensives and worsen their ED. I think we need to address his problem of ED, which is a major source of distress. I know BPH is a problem, but how much is he passing urine anyway? I mean, how much is BPH creating problems as far as his urine is concerned? It may not be much. So if the BPH is not creating obstructive symptoms or not troubling him, then I think the drugs, he can reassess and withdraw these medicines or go ahead and get his BPH operated and then do away with finasteride and dutasteride and other medicines.
Thank you. So we have another question from Masimango Iman. He wanted to know about sex, I think, in GFR estimation equation.
Madam, I didn't get the question.
He just wanted to, for you, if you can elaborate more on how sex affects GFR estimation equations.
It does. It does. I think all of us know that sex affects GFR estimation. More than the sex affecting a GFR estimation is the way we use GFR and we sort of prescribe drugs, prescribe adequacy of dialysis. The biggest problem of the KT over V 1.2, which we use for men, may be adequate, but in women, it often leads to underdialysis. The second issue is writing, like when you have aminoglycosides and your GFR is less than 15, you give it 48 hours. Again, you are overestimating the GFR of women. The woman may not be 15, she will be 12. And if you sort of give that drug, you are creating much more toxicity. So sex makes a very important role. And I'm sure if you go into the Kidney International paper on how sex hormones modify GFR, amazing the effect of intraglomerular pressure, GFR, how estrogen is beneficial and testosterone is not. So sex hormones matter with kidney function, sex matters with GFR estimation, and this fallacious use of one size fits all actually puts women at a disadvantage because they develop very high toxicity with drugs, because then they're not supposed to be getting the same dose what men get it. They should be getting it much less. So there are problems with.
Thank you. Moise Musafiri is asking, is good dialysis clearance has a positive effect on this issue? Or
yes,
it will
madam.
Not
yeah,
any...
it has actually makes a difference to all the majority of sexual dysfunction. A good aggressive dialysis actually helps improve erectile dysfunction, improves your cardiovascular mortality in men. And most importantly, as dialysis delivery has improved, pregnancy in women is becoming a reality. When we were students, we used to hear pregnancy in women in hemodialysis was unheard of. Now, there are NDT registry has shown between 2006 and 2012, they have reported more than 600 pregnancies. So I think a good quality of dialysis really makes a difference. And I'm sure in your part of the world also, as dialysis improves, patients live longer, their quality of life improve more. They move from the physical domains of quality of life, these issues with you. We are beyond, urea creatinine now. We have to give them a better life.
Thank you so much. I think I have exhausted all the questions from the chats. I
really thank you. There are comments about my background. Yes, that's a transplanted kidney. It is the gift of life. And I think all the dysfunctions, majority of them improve if you transplant this patient.
So now maybe I would like to ask any of the panelists who would like to give comments or to ask questions. Otherwise, I'll return the session to Dr. Egina.
Thank you. Yes, Lloyd?
One last question. Sorry, it's very late. I know it's very late. The
That doesn't matter.
psychosocial
Don't worry. Don't worry.
Sorry, the psychosocial impact of this on patients. Is there a lot of literature on that? The psychosocial impact. There's a lot of impact when you have erectile dysfunction.
Yes, yeah.
So, is there any sort of literature that you've come across that is like highlighting this and how they have sort of dealt with it in terms of treatment? Is there anything?
Yeah, Lloyd, there are a lot of literature. Unfortunately, I just put on the physiology of it all now. But these domains, if you look into the quality of life questionnaires, they don't discuss all this with our patients.
Yes, correct. Yes.
The majority of the questionnaires don't ask these questions straightforward.
Yes.
It appears sexual function is only for the youngsters, not for our group of dialysis patients, middle-aged. And
yes,
there was some paper about a marital discord because of ED in CKDs. There was some instances of, but they have not been sort of being able to look. And I think we need to revisit all these questions when we ask our patients. And I don't do it, Lloyd, much, but I think slowly.
Yeah, sure. Thank you. No, lovely presentation, Urmila. Thank you very, very much. Exhaustive presentation and so much.
Thank you. I took a lot of time of yours, but
no, thank you so much. Wonderful. So many people need the slides, so I'm sharing your slides across the board. Thank you very much.
Thank you very much. Thank you.
Thank you, Urmila. That was an excellent presentation. But before we close, I think there is one question that I think is very important. The use of sildenafil. Can you hear me?
Yes, sir.
Yeah, there is one question from Maingu Matoke, who is asking about the role of sildenafil. Can we prescribe sildenafil to our patients?
We can actually. Can it help? We can actually, but then there is a major problem. The drug sildenafil are acting through nitrous oxide. There is a deficiency of nitrous oxide in our patients, and the vasculature, the penile vasculature is atherosclerotic and dysfunctional. So the drug does not work that effectively. One. Second issue is you have to caution your patients because all these drugs are over the counter. So the dose that you give to them, they should not overdose themselves. Thirdly, most of our patients have cardiovascular issues. So before you want to prescribe these drugs to your patients, be sure they don't have significant cardiovascular problems. I have not, but my colleague have prescribed it in youngsters. They have, some of them have shown benefits, but sometimes what they do, they get used to it, and then they realize that whatever the original dose is not working, let's take another. The tablet is not going to work much if it is not going to, if the vascular flow to the penis is not very good. So these are the things you need to discuss. And yes, there are studies of using these drugs, as I mentioned in ED. There are 5 studies which have shown some benefit in dialysis patients.
All right. Thank you, Urmila. Thank you very much.
Thank you very much. Pleasure, Lloyd.